Okay, hello everyone and welcome to your vascular surgery teaching part 1. My name is Hannah. I'm a doctor in F2 in KSS.
And my name is Mohammed. I'm also a doctor F2 in KSS.
So part 1 today is going to be focused on chronic vascular pathologies. So we'll run through some cases and some of the basic background based on the MLA curriculum with hopefully some useful clinical stuff to help prepare you better for F1 as well, because that's the end of the road. So to start with, we'll go through the aims of the session. So these are taken straight from the MLA curriculum. Are all the different presentations that you're expected to know for the MLA. And then in another section, it mentions post-surgical care and complications, which actually will be quite a heavy point of anyone's work as a surgical F1, be that in vascular surgery or anything else. So that's why we've added in some bits to prep you. Obviously, we'll be covering a lot of the salient points that you need to know for the cases that we're going through, but I imagine that a lot of this will be a revision for a lot of you. So if things aren't making sense, then maybe, particularly if you're watching this as a recording, just go back, go through some of the basic anatomy, familiarize yourself with some of the pathologies. So this is, more of a revision and application of your pre-existing knowledge. So to start off with, we'll talk about peripheral vascular disease. It's a very common presentation in GP and in secondary care. So everyone will come across this, be it the primary presentation of a patient or a comorbidity that will affect their care wherever you're delivering it. So it's estimated to affect 20% of people aged over 60. So you'll definitely be coming across it. It has obviously a lot of consequences for the patient, a high symptomatic burden, preventing them from doing their day-to-day activities if it's not managed properly. Obviously, the underlying processes that cause peripheral arterial disease and something like intermittent claudication, they're also going on all over the rest of the body. So you've got cardiovascular complications associated with PVD. And then you've got the complications of management. So a lot of patients are on long-term opiates, which we all know have a lot of side effects. And, whether things are being managed operatively or not, people will often present to hospital, be that because of pain or kind of acute on chronic presentations. So it can have a really high burden on the patient. The key risk factors to know, and this is really important for exams, both OSCEs and written exams, smoking. So always ask about smoking, diabetes, hypertension, and hypercholesterolemia. So the common bunch of risk factors for cardiovascular disease, but in particular smoking, and that's obviously the most modifiable in the sense that it's something that we can try and tackle, but it is obviously also really difficult for the patient. So a presentation, intermittent claudication, you might already know what that means, but the definition or the features of it are, and what patients will describe is either a fatigue or kind of cramping pain. They often don't describe it as cramping per se, but they'll kind of describe a general picture of their lower extremities after a certain amount of exercise. So they might say, oh, I can now only walk the dog 1 mile. So kind of repeatable amount of exercise. They'll find their typically the lower extremities start hurting and become weak. And that can also be associated with some sensory changes. Thinking about investigation, so taking a really, really good history, because, leg pain, there's quite a wide differential for that kind of thing. And leg weakness, you also want to be excluding neurological things. So there's a lot to unpick. And that's when it's particularly important to get into the past medical history, and the social history, because that's when you're asking about something like smoking. And that's very, very important for your OSCEs. Then the examination. So, if you get to the point where you think that there might be a vascular pathology underlying, then you want to be doing a full pulse examination. So we'll go through all the different pulses that you'll be looking for. And then your blood, so to establish all of the risk factors that might be contributing to it. So your baseline bloods, but in particular, you also want to be doing a lipid profile and an HbA1c to see if there are specific things that you can be modifying. And then other bedside investigations, so your ABPI, ankle brachial pressure index, is a very useful tool for stratifying the extent of peripheral vascular disease, and it it allows you to establish a trajectory as well. And imaging we'll talk about more in the emergencies, because that's typically something that will happen in secondary care. This page is more useful for more a framework for your OSCEs and kind of things to be thinking about when you're taking a history and doing an examination. So the pulse is very important in any vascular exam. Palpate for the abdominal aorta, or at least say that you would be feeling for the abdominal aorta. So here we've got a nice diagram of the surface anatomy of where different abdominal arteries will be found, and then you can also see where we would palpate for the femoral artery. And with examining for an abdominal aorta, it kind of it feels a little bit abstracted to do on a patient who doesn't have a pulsatile abdominal mass, but just practice on healthy people, practice on patients on the wards, and then you'll just get more comfortable with the actual process of doing it, rather than just sort of putting someone on the belly and leaving it at that. And you can also find lots of videos on YouTube to kind of aid you. And now, so going to the lower limb, we've obviously shown you the surface anatomy of where you'd look for the femoral artery, but this is a nice diagram showing how the external iliac vessel turns into the femoral artery when it passes through the inguinal canal, and then kind of produces perforating branches. So other pulses that you're going to be looking for are the popliteal pulse, so behind the knee. I don't know if you can see my mouse, but that's where it is. The posterior tibial artery, so you'll be, we'll move on to the next slide. It's just, as you can see on the top image, it's just posterior to the medial malleolus. So it's, you can try finding it on your own foot, but it's best to practice on someone else, because the ergonomics of getting your hand around the right place are quite different. So definitely practice on someone else to kind of get comfortable with it. And it can be a bit tricky to find, particularly on older patients. So, just practice on people with good sort of vivacious pulses, so that you can get comfortable knowing where it is. Similarly, the dorsalis pedis, So that is going to be the way to, a trick to find that is ask someone to flex their big toe, and that will show you the extensor hallucis longus tendon. And then if you go just lateral to that, you'll be able to feel the pulse, and feel quite lightly, and you should be able to find it. Okay, and the ABPI. So this is essentially, you need a Doppler to find blood flow in the leg. So what you can see is they're looking for the dorsalis pedis and the posterior tibial pulses. You inflate the cuff and then deflate it, and as flow comes back into the artery, that's the systolic reading that you're taking. And then the same thing is done on the arm for the brachial artery, and that's used to produce a ratio. And we've got the kind of the ranges here and what they would suggest. So 1 to 1.4 is normal, less than 0.9. You're thinking, obviously, in conjunction with your history and examination, that peripheral arterial disease is quite likely. If you're going to less than 0.5, that's suggestive of, that should say critical limb-threatening ischemia. And then you've got some readings of greater than normal, which is going to be found in patients who already have very extensive calcification of their vessels, so people with diabetes, because the vessels become so non-compliant that you basically get this falsely high reading. So it's a very useful tool, but it should be used in the context of all the other things that you've done, which is why it's so, in terms of diagnosing and making plans going forward, a lot of it is based on the history that the patient gives, and everything else around it is not just the numbers you produce from an ABPI, but it is very important to do. So when we're thinking about management, the kind of definitive management for it is a combination of reducing or even reversing risk factors, which is smoking cessation, diabetes control, diet control, and cholesterol management, and a supervised exercise program. So it's a very stringent thing that patients are enrolled on, where essentially they're encouraged to walk to the point where they have maximal pain, can't go on anymore, and that is extended every week in specific, like, quite rigorous sessions, and they will find that they can go further and further every time. So it's very useful, and thinking about OSCEs and things, it's a good point for motivational interviewing, because obviously patients, they might not feel like it's going to work initially, but actually it really does. We've touched on risk factor modification, analgesia, obviously. So start with the minimum, paracetamol. A lot of people have contraindications to ibuprofen, but before moving up to opiates, because people, this is a long-term condition. People will be struggling with this for a long time. So if you're whacking them on opiates straight away, that can have serious consequences for them later down the line. If you are going to be putting them on opiates, consider things like laxatives, counseling on the fact that you can become dependent. And then there are some specific medications for intermittent claudication that people can be put on. And obviously referral to a vascular MDT, because they'll be the ones making the decisions on whether somebody would be for surgical intervention or not. Okay. And then, so let's say you've tried this with your patient, or in the same consultation, the patient says not only is it that they're not able to walk more than a mile, before getting a lot of pain, but actually they also have a lot of pain at night, and it gets worse throughout the night. And they find the only thing that helps is getting up and swinging their legs over the bed, or even more, some people will say that they actually can only sleep in a chair. So that's rest pain. And it happens because at night our blood pressure goes down. We get less perfusion of the extremities. Obviously, in someone without peripheral vascular disease, that doesn't cause a problem. But in patients who are already on the cusp, it's going to worsen their symptoms. And that's a feature of, again, that should say critical limb-threatening ischemia. So if somebody mentions that, that's a much more sinister symptom, and that's where they should be urgently referred to the vascular MDT. So you might recognize this as Berger's test. A lot of people with peripheral vascular disease won't be positive for the test. It's quite late stage sign, but essentially what you do is you elevate the limb to 30 degrees and hold it there for a minute. And the test is positive if the foot goes completely white. So I think this is quite a nice photo of how it works. So you can see this foot has gone completely white. And this patient has critical limb-threatening ischemia. And then when you put the limb back down, you essentially, because the limb has been deprived of any blood flow, you get this reactive hyperemia and inflammation as all of the blood starts going back. So this kind of dusky reddish bluish color is again kind of part of the test. As I say, in a lot of people it won't be positive. That doesn't mean they don't have peripheral vascular disease, but it's still useful and particularly something you can offer to do in an OSCE. Okay, so as we've mentioned, critical limb-threatening ischemia is essentially a clinical diagnosis made on the basis of several features. So this chronic rest pain that I'd mentioned, if you're getting ulceration, the dependent route, so positive Berger's test essentially, or completely absent foot pulses, they need to be referred to a vascular MDT, regardless of whether you feel that they would be fit for surgery or not. That's something for them to decide. And it's all another important thing to think about as a clinician, be this in primary care or if you're working in A&E, is their fitness to drive. So this is quite a useful, an extremely useful tool, which lets you, it is basically just a tick box tool for you to work out what you need to be doing and what you need to be advising on for these patients. So that's always a good thing to go to. Okay, and now Mo will take over for ulcers.
Fantastic. Thank you, Hannah. So onto ulcers then. As you can see on the screen in front of you, typically we categorize ulcers based on whether or not they are venous, arterial, neuropathic, and of course there's multiple causes of neuropathic ulcers. Typically, the majority of them will be as a result of diabetes, so peripheral neuropathy caused by diabetes, but also there can be other causes, including hereditary causes or acquired causes due to maybe B12 deficiency caused by alcoholism, or sometimes even chemotherapy. There's various different causes. So they're our rough categorizations for ulcers. So if we start off with venous ulcers, and we can see here a typical image of what one may look like. Now, venous ulcers are essentially, they're caused by venous insufficiency that leads to an increase in venous pressure and as such, poor oxygenation of the tissues. So essentially there is not enough oxygen supply, and as a result the tissue in that particular area is eroded. Typically the location is what is referred to as the garter region. In other words, basically more so the dorsal aspect of the foot. And again, in terms of the history, it may be in line with a generic history of peripheral vascular disease of the venous kind. So perhaps some leg swelling, perhaps there's also a history of varicose veins, just general maybe skin changes around the region as well. So it would all fit in with a history of venous disease. Now, the appearance of the ulcer is important because this will help you, along with the location, differentiate it from different types of ulcers, such as arterial, for example. So typically, venous ulcers are shallow, so they're not very deep, and they have quite irregular borders, and that's very different, as I'm sure we'll come across in a second, to arterial ulcers, which tend to be quite deep, that generally have smoother borders as well. As for the appearance of the rest of the skin, there's going to be venous eczema. You could get hemosiderin deposition, which is essentially a darkening of the skin, and typically that affects both legs. Sometimes it's referred to as champagne bottle legs, but when you first see it, you'll know it straight away. It's this dark brown color, and it's quite typical. Is it painful? Not typically, but it can be. So sometimes patients don't feel any pain, and they won't really have necessarily noticed it, especially if they've got dementia or they're delirious for some time. So don't always go looking for pain. And in terms of the pulses, they may well be normal because it's not an arterial cause, it's a venous cause. So that's venous ulcers. In terms of further investigations and management that you'd want to do, so it's important obviously to perform a duplex ultrasound to look for venous insufficiency. And of course, again, any risk factors, and again, they're going to be similar to what Hannah's mentioned already. So if they're overweight, then we would encourage them to, try as best as they can to lose some of that weight. We give them some dietary advice. And of course, if there are any varicose veins, then we'd look to treat those in the various means possible. It's important, though, to also treat any underlying infection. So venous ulcers are kind of a breeding hub for bacteria. They typically can get infected, and it can be kind of a cause of cellulitis of the surrounding tissue. How do we treat venous ulcers? That's primarily through compression bandaging and also applying appropriate dressing to minimize infection and keep them from spreading any further. Of course, you'd also want to do an ABPI to rule out that there's no underlying arterial disease, because if there is, then of course the management for that differs. Okay, something really important is remember to always expose the patients that present to you with legs with dressings on. And you won't just see this on the vascular ward, you'll come across it in the GP setting, you'll come across it in the acute med setting. I remember seeing many cases on my acute med rotation of elderly individuals that come to hospital, maybe with a cough, maybe with a fall. So you may not think, initially that this person may have ulcers, but then you find that their legs are wrapped in this very, extensive dressing. It's very important to expose the patient and to have a look, because like I mentioned in the previous slide, these are breeding grounds for microbes, for bacteria, and can easily become infected. If they are infected, then the patient as a whole may develop a fever, they may become cellulitic, they could even become septic, and like I said, they may present with confusion or a fall, especially in the elderly population. but it's important to look for the underlying cause, and one of which it could be infected ulcers. So always expose the patient appropriately, look for possible ulcers, infection sites, particularly in those with reduced mobility, and that includes those wearing compression bandages as well. Fine, that's kind of venous ulcers. On to arterial ulcers. Now, of course, arterial ulcers are caused by arterial disease. And as we know, that's essentially a buildup of plaque and narrowing of the arteries that supply the lower limbs. Now, once again, typically they're in the what's described as the garter region, or again, just the dorsal aspect of the foot, really. And as part of the overall presentation, they may have already complaints of intermittent claudication. So again, they're complaining to you that they are now struggling or getting cramps when they walk up a hill, so any kind of incline, or beyond a certain distance. Alternatively as well, they can present to you complaining, especially if it's someone that doesn't move around much. And this is kind of the difficulty with patients that aren't particularly mobile, is that they may not kind of realize they have peripheral arterial disease because they don't walk that much. So they don't test kind of or notice that they have any change in their ability to walk long distances. But something to ask for is night pain in legs. And the reason for that is, of course, when a person is asleep and they're lying flat, then the blood supply to the lower limbs isn't as good as when the patient is standing upright during the day. And obviously gravity helps with that. So that can be a common sign to look out for, particularly in patients who aren't as mobile as others. Now, as I mentioned earlier, the appearance of arterial ulcers, typically they have quite a sharp border. They're punched out in appearance and can have kind of a necrotic base. The rest of the skin around it should be dry, should be quite pale. You might get hair loss, which again is typical in patients with peripheral arterial disease. These types of ulcers are definitely painful. And of course, there could always be one or two that don't fit the trend, but generally speaking, these are painful ulcers. As for the pulses, if you were to perform a vascular exam, then you'll notice that the pulses may be absent or may be reduced. And once again, that's because of the cause of these ulcers is arterial disease. So you'll find that maybe you're struggling to feel for the dorsalis pedis pulse. So that's kind of what you can expect to find on examination. So if your patient reports a history of claudication or night pain in legs, then remember, arterial ulcers or rest pain of a duration of, for over 2 weeks is essentially, these are signs of critical limb threatening ischemia. And these patients need to be referred to a vascular surgeon for further assessment. Okay, on to our third type of ulcers, and these are neuropathic ulcers. So if we look at the image, so typically these are located at the bottom of the feet, by the balls of the foot, or basically areas, pressure areas of the foot. Now, the cause of this, as kind of hinted at by the name, is an individual is unable to actually has got basically sensation has been affected due to his neuropathy. So he's unable to feel any damage that takes place or breakdown that takes place to that area of skin or tissue. So it can start off by potentially a small cut or some kind of small abrasion to that particular area. But because the patient has not noticed it and the patient does not feel it, it grows over time. They don't tend to it, of course, because they don't know it's there. And, before you know it, the ulcers become quite deep and quite serious. In terms of how it looks, of course, the depths will be variable, but again, it will be similar to arterial ulcers in the sense that it's got that punched out appearance to it. But of course, the main difference here being the location. These typically tend to be the bottom pressure areas of the foot. Now, again, the location may or may not be affected by any abnormalities that affect the foot. So Charcot's foot, for example, may cause the ulcer to appear in an area that's atypical. Once again, the ulcer shouldn't be painful, typically, and that's because, again, the patient has got peripheral neuropathy. They're not really, their sensation isn't, what's normal for other patients. And so typically they won't feel much pain associated with this ulcer. But again, there are always individuals that fall outside of the general trend. With regards to pulses, if you were to perform a vascular examination, this is entirely dependent if there's concomitant arterial disease. So if there's arterial disease at the same time, then of course the pulses will be affected. You may not feel them, or they may be, much weaker and much more difficult to feel. If there is no arterial disease, then the pulses should be fine, and you'd be able to feel them as you would in any other patient. So if we take a look at a case with a 64-year-old man with an ulcer, so his history of presenting a complaint.
Oops, sorry.
He noticed an area of ulceration on his left foot. It's been getting worse over the past few weeks, and he's finding it is sticking to his sock, and there's no ulceration elsewhere. He denies fevers or other systemic symptoms. In his past medical history, he's got type 2 diabetes, which was diagnosed recently with the GP, and he's unsure of what his HbA1c is. He's got mobility issues, what he describes as mobility issues on the left side. He is a smoker, but he does not drink alcohol. So take a minute here and think, what could be your differential diagnosis in terms of what are the potential causes of the ulcer? And it's important to take hints from the history and see what you think from there. So I'll pause it for a second, and then if you're watching the recording, pause and then carry on after. Okay, if we move on maybe to the next slide. So on examination, you find his foot to look like that. Now, those of you that are familiar with this, you should be able to spot that this is Charcot's foot. So this is what he was describing as mobility issues in the slide earlier. Now, as you can see, the location, it's kind of overlying a particular prominence of the foot. But remember what we said about the location. There are typical locations for each type of ulcer, but those locations may be affected if there is an abnormality or a deformity to the foot, as is in this case. As for the rest of the skin, so as we can see, the foot appears to be deformed. There's other shallow areas of ulceration on pressure areas. There is hair loss, but there's no obvious chronic venous changes. Is there any pain? He says there isn't. And as for the pulses, they're good femoral pulses, but weak posterior tibial pulses bilaterally, and you're unsure about dorsalis pedis. Perhaps you're unable to locate it properly due to the deformity. So what's the likely diagnosis here? Well, it's Charcot's arthropathy with neuropathic pressure-related ulcer. So really, it was a bit of a cheeky case because there's multiple, things that may get you to suggest one type of ulcer over the other. For example, his diabetes may help you to suggest that it's a neuropathic ulcer. Smoking history, again, especially with there being some hair loss on examination, may point you towards there being a level of arterial disease. And obviously, Charcot's foot, finding that on examination. The reality is, though, this case presents what you may typically find in the hospital. Patients are more complex, and often there can be multiple causes or perhaps even multiple types of ulcers on the same foot. So that's an interesting case to cover. Okay, so what are the next steps? So in terms of your ulcer management, you want to complete your full examination and investigations to look for any coinciding arterial disease. Remember, that's obviously very important to tackle and manage as soon as possible. And depending on the depth of the ulcer, how badly infected it is, if it's causing severe pain and the location of it, etc., you'd need to consider whether or not this would require surgical debridement. If it would, then of course this is done by the vascular team. As for Charcot's arthropathy management, then this needs an urgent referral to the foot service. This may vary, to be honest, from one trust to another. So obviously look at your local guidelines, whether or not you'd get the podiatrist involved, or if there's an alternative route there. And of course, you need to remember that the ulcer ultimately is a symptom or a sign of an underlying disease. So if it's caused by arterial disease, then really, as well as treating the ulcer or managing the ulcer, we need to treat the underlying arterial disease. If it's caused by neuropathy secondary to diabetes, then of course we need to manage the diabetes, get on top of it to avoid any further neuropathy or any further consequences of that diabetes. And likewise for if the cause was venous. So for those of you that are live, are there any questions? Remember, you can use the chat function. And if there isn't, then or why don't we'll take a short break now, maybe 5 minutes or so, and then we'll keep an eye out on the questions in those 5 minutes if you are happy to submit them, and then we'd answer them once the break is over. Sound good?
Okay. Bring your questions in. We'll be back in 5.
Lovely.
Okay, so just to address some of the comments, thank you for those participating. So someone had mentioned about exposing the legs. The implication is that someone has to redress the leg with the correct combinations. Is true. That's why we put that in there, is because as an F1, you might be quite hesitant to take down the hard work of someone else, and you're not really sure how to redress the leg or who's going to do it. But you have to think that you're essentially not completing your examination of the patient if you don't undress the legs, and think about the potential consequences of not exposing someone properly, of missing a cellulitis, compared to this, like, having to ask somebody who is competent to put on compression stockings slash compression bandages. So there will be people around that know how to do it, and it does mean that they might miss out on a couple of days of their management of their venous ulcers, but ultimately it's more important to make sure that that there isn't an infection underlying. So it is really important to take down the compression bandages. Yeah, and the other comments were live during the case, which we agree with. So I'm going to put the chat on to show on stream, so that everyone can see the comments, so we can sort of get some good participation. I think we'll start the next session at 7:30. So for part 2, just in case anyone was planning to join at 7:30, so that they don't miss out on the first part of it. But keep your questions coming, obviously. Mo, are you there? I can't see.
Yeah, I'm there.
Okay.
Just busy reading the comments, that's all.
Okay, we've realized that it is possible for anyone who joins in a bit to rewind to the beginning of this. So we're just going to crack on with the next session, so that we're not keeping anyone who's currently on waiting. So am I still sharing my screen? Yes. Just write a message in the chat. Okay. So, vascular surgery part 2. Here we'll be going through our vascular emergencies and some tips about how to work, or, what it will be like as a surgical F1. Obviously, we can't prep you fully. A lot of it will just be a very steep learning curve at the beginning. But what we can do is point you towards some tools that you can familiarize yourself with, so that they're a little bit less daunting when it comes to doing it on the job, and people sort of just expect you to know it. So again, we'll go through the aim. So we've been through arterial ulcers, venous ulcers, and peripheral vascular disease in the previous session. Anyone who's just joined or is watching the recording, obviously feel free to go back and look at those, because what we'll be focusing on in this session is aneurysms, the acute ischemic limb, specifically aortic aneurysm and AAA, and then the kind of post-surgical care and complications. Obviously, we can't cover everything on the curriculum, but we'll cover the most I guess actually the more interesting things. I mean, it's all interesting. Move on. Case 1, you've got a 75-year-old female who's a nursing home resident. You're working in A&E, and the nursing home have called an ambulance for her. You're given the history of the presenting complaint, so she's been like well recently. Obviously, what well means, it differs from person to person, but that's the history that you're given. And then this morning, she seemed more agitated and more confused than usual. So the fact that this is than usual should be suggesting to you that maybe her baseline actually is a little bit lower, and it's possible that you're not going to get a full history from her. So then you need to be thinking about how else can you find out the history. But it's important that to the people that know her best, which is going to be the nursing home staff and obviously family as well, she seemed like her normal self until this morning. So this is maybe an acute thing. And crucially, she wasn't able to transfer from her bed to her chair, which she normally is able to do. So past medical history, she does have dementia. And in combination with the history that you've been given, you can infer that she has a slightly lower cognitive baseline. Atrial fibrillation, type 2 diabetes is diet controlled, and stable angina. So what we're already thinking is there are a few cardiovascular risk factors, and therefore risk factors for peripheral arterial disease. Social history, previous smoker, and that's all we're given. So yeah, you can picture this patient in A&E. You'll often see patients like this in A&E. And you go to examine her. So the first thing you always want to look at is their OBS. So her NEWS score is 2. So what she's scoring for is the heart rate is a little bit raised. And everything else seems fairly normal. So normal temperature, blood pressure, obviously that depends on what someone's normal is, but it's not horribly high or horribly low. You're doing your kind of general cardiorespiratory exam when you're clerking someone in A&E. Hands feel kind of fine. Radial pulses, you can feel them both, but they're maybe a little bit thready, and she's a bit tachycardic. Doesn't seem particularly dry or overloaded. You can hear the heart sounds, the chest is clear, and the abdomen is soft and tender. You can't feel any pulsatile masses. And then as you're examining, someone comes in, so the healthcare assistant comes in and gives you a VBG that they've just done because they've just been taking the bloods and they've done an ECG. So take a moment to look through this, quite a lot of information on one slide. If anyone who's live wants to put comments into the chat, then please do. So what we can see is a fairly unremarkable VBG. So obviously we start by looking at the pH, that's normal, which is good. Electrolytes looking fine, glucose is also fine. But the lactate is a bit raised at 3.9, which we might not be horribly worried about initially because the pH is still normal, but it is odd. And whenever you see a raised lactate, think about what can be causing that. Lactate will often be a little bit up in lots of patients coming through the door at A&E, but 3.9, that's significant. And the ECG, so this is just a little bit of AF. But we know that she has AF. So you've got some information, but obviously not all of it. Be thinking the whole time as I'm reading these things out, what are you ruling out? What path are you being led down more? And think about what else you would do, what you'd ask about. So there was quite limited information in that examination, because we actually, obviously, a part of every cardiorespiratory exam, you want to go and feel for the calves of any tenderness, look for any swelling, and then you expose her legs and see this. So again, take a moment, think about what do her legs look like, what's worrying here, what would you want to do next? So you want to have a feel. What does the temperature feel like on both legs? And how does it change along the legs? So are you going from warm to cold, or is it completely cold throughout? Is one warm, one cold? Do the capillary refill time, do it properly. You should always be doing it properly, but in this case, really do take the time to do it. Test their sensation. In the context of this patient, that might be a bit difficult because she's got a lower cognitive baseline. But in any patient where, always try with everyone, but particularly if they are normally able to feel that sensation, establish what their baseline is, and then see if it's impaired. Ask them to move their legs, compare one leg to the other, and then doing the rest of the holistic stuff. So having a look for any scars. Have they had surgery before? Does anyone in the chat want to say why we're thinking about a popliteal aneurysm? So it's because I imagine most of us are kind of, given that this is vascular teaching and vascular emergencies, we're thinking about acute limb ischemia here. And one of the causes of acute limb ischemia, particularly such a sudden onset, maybe not in this type of patient, but is a popliteal artery aneurysm, because it can throw off an embolus and cause very sudden ALI. And as I kind of mentioned throughout, but it's really important to not just look at the leg that you're interested in, but to compare to the other leg, because that will give you a much more robust picture. It's just do it, basically. So I already went through this in the previous session, so apologies to anyone where this is kind of going over it again, but that is how best way to learn is to just do it again and again. So you want to be doing a pulse examination in this patient, feel for the abdominal aorta, and then go for your lower limb pulses. So bilaterally, the femoral pulses, have a good feel. Then move on to your popliteal. Again, feeling for any aneurysm or anything like that, but also you just want to be feeling anyway. And then you've got your posterior tibial pulse and your dorsalis pedis. So I'm going to go over it again just for anyone that didn't watch the previous session. Your femoral pulse, surface anatomy, so you're going midway between the pubic symphysis and the ASIS. The popliteal pulse is in the popliteal fossa, so we kind of cup the knee, fingers at the back, and then that's where you would feel it. Posterior tibial pulse, posterior to the medial malleolus. So as I kind of mentioned before, feel it on your own feet and then try it on someone else because it's different and you want to get used to doing it both ways. And the dorsalis pedis, again, ask the patient to flex their big toe. That will reveal the extensor hallucis longus tendon, and then you can feel lateral to that. So the diagnosis here is acute limb ischemia. I hope everyone kind of came to the same conclusion. And this is our classic 6 Ps. So we've got pain, so that explains in someone with dementia, she wasn't able to communicate her pain, but presented more with just being generally restless. People might say off legs, off their baseline. There are lots of different ways of describing someone not being quite right, and often these are manifestations of pain in someone that can't express it through the usual routes. Pallor, so the limb being very pale. Pulselessness. Paresthesia, so any sensation changes. Perishingly cold, and paralysis, so an impairment of motor function. The 6 Ps are very much at the end of the line, and at that point, the patient or the patient's limb is very much in trouble if you're seeing all of these signs. So don't think that just because they're not all there, that it's not acute limb ischemia, because the people that, the patients that you really want to catch are the ones that are early. And it can be quite nuanced because a lot of patients with acute limb ischemia, it will be on a background of kind of chronic changes, so critical limb-threatening ischemia. So there'll be a lot of skin changes, and a lot of these signs like the pulselessness will be there as well. And that's why it's so important to compare to the other limb, because it will give you an idea of what their baseline is compared to what has changed. So this is the Rutherford classification for classifying acute limb ischemia. So there are, and essentially what vascular surgeons want to know is it viable? Is it threatened, or is it irreversible? In which case, you're going from having revascularization surgery potentially to needing an amputation, because if you're at the point of a Rutherford 3, then you're actually basically life is at risk because of the degree of ischemia, because that can put you in such metabolic disarray that you're going to need to go for an amputation. You don't need to learn this for your exams, but it's definitely good to consider for your jobs, because when you're making a referral to vascular, it will definitely be helped if you have, not for you to be able to say, oh, they're Rutherford, whatever, but to at least know some of the features that they'll be thinking about when they're classifying the patient in their heads, because often these referrals will be going over the phone. And this is just another image which is, again, goes to show that it's can really vary what you see on a patient. So this is kind of showing an increasingly mottled and dusky appearance. So this is the P of the kind of pallor of the 6 Ps of acute limb ischemia, but then as you progress, you'll get this mottled appearance, which does look extremely abnormal. Like, it won't look like a well perfused limb at all, but don't mistake the mottled appearance for it not being an ischemic limb. So let's say we're still in A&E in the kind of assessment area. You suspect acute limb ischemia. What are you going to do as an A&E F1? And this can also apply to, if you're working as an F1 on a geriatrics ward, for example, and this has been flagged to you by the nursing staff. So to aid our diagnosis, we can do an arterial Doppler, because that will give us an idea of flow. If there is a Doppler signal, then you can do an ABPI. If you are fairly sure from your clinical examination that it is acute limb ischemia, then you want to be assessing the severity of the damage. So doing serial VBGs, because obviously this is an evolving state and you want to know how things are changing over time, to look for the lactate. Are they becoming acid? Was this patient with a lactate of 3.9 but a pH of 3.6 2 hours later? Have things changed? Do a creatine kinase, because when you get the muscle damage, it will be obviously like releasing CK, and then you've got all the sequelae of that, which I won't go into, but that's another thing to think about. And then for any patient, consider that they might be going for surgery. So it's helpful to do bloods like just the kind of typical pre-op blood. So take a group and save, do a coax screen. And the most important thing really is to be calling vascular surgery and call them early, because they'll want to know and they'll want to assess the limb themselves. Analgesia for the patient. So it's extremely painful. Patients get a bolus of heparin, because there's going to be, so in terms of the pathophysiology, we'll go on to that, but essentially, we know it's caused by thrombus, and we don't want that to propagate and worsen things. IV fluids, oxygen. So there isn't actually, my understanding is that there isn't sort of evidence behind the oxygen, but that is in the guidelines, and that's in the RChem guidelines for emergency medicine. And imaging. So typically people go for CT angiography, but you can also go for MR angiography. I would say from experience, call vascular straight away. Like, don't wait for CT angiography to come back. And if you're in A&E, you'll be guided by your seniors about what to do anyway. But people go for different modalities. Okay, so management. Obviously, these wouldn't be options for you to be deciding on, but just an awareness for OSCEs and interest. We've touched on the fact that surgical management really depends on whether the limb is viable or not. And then we also need to consider, is this a thrombotic event or is it an embolic event? And we'll go into what thrombotic versus embolic is. And another consideration will be whether surgery is actually going to be of benefit to someone, or if this is maybe more of a terminal event, and palliation would be the kind of best interest decision. If someone, if you've got a fairly fit and well person who is going to be going for surgery, then later down the line, obviously, you will need to be, if they're not already on some sort of medical management to reduce their risk of future events, then we need to be modifying their risk factors as well. And that's obviously important to know as an F1, because you'll be starting these medications in someone's discharge summary if they aren't already on them. Okay, so you've mentioned this thrombotic versus embolic event, and often thromboembolic, they get put together with thromboembolic. So a thrombus forms in situ. So what you can see from here is this is someone's artery. They've got some atherosclerotic disease. There's a plaque there, and essentially, because that's like a prothrombotic surface. If you're thinking about like Virchow's triad, you're going to have a thrombus forming here, and if that forms in a particular place, then and that thrombus occludes the artery, then from that point forth or distally, you're going to have acute limb ischemia because the blood supply has been completely cut off. So typically this will form in the context of someone who already has peripheral arterial disease. So your patients with CLTI. There are other causes. So think about malignancy, hypovolemia, that's rarer. And then the clues really are in the history. So thinking about this patient, she did have some, she had angina. So as I was saying before, atherosclerosis is a global process. So if someone has coronary artery disease, they are also going to have a degree of peripheral arterial disease. And then again, the importance of comparing to the other limb, because the other limb may well have abnormal pulses as well. And that will be an indicator as to the fact that maybe this is a kind of acute on chronic etiology rather than some completely new presentation. Okay. And that is compared to an embolus, which actually this patient could also have had. So we've purposely given a case where it could be going down either route, because if you remember, the patient had atrial fibrillation, which we know can throw off a clot. And in an elderly person, sometimes they're not on anticoagulation because their bleeding risk might have been assessed at some point to be higher than their clotting risk. So they wouldn't necessarily be anticoagulated. So when you see that someone's got atrial fibrillation, think, are they anticoagulated? Because that's important for kind of both ways. So with an embolic acute limb ischemia, again, it's the onset of symptoms. If it was very sudden, it's the context of the patient. If you've got normal pulses on one side and completely abnormal pulses on the other side, then there probably isn't underlying atherosclerotic disease, and this is more likely to be embolic. So the prognosis of acute limb ischemia is not great. It's got a high mortality rate for various reasons. And then even in those who do have an intervention, you can get the post-operative complications. So essentially you get a reperfusion injury because the blood supply has been cut off for a while. It's kind of gone back. So you get this essentially like reactive overperfusion, which will lead to edema and compartment syndrome. Lots of potassium is released from the damaged cells, so you can get a lot of metabolic derangement, and people do die from the post-operative complications. So that's maybe something to familiarize yourself with if you are coming onto a vascular job, because spotting this, you'll be the person on the ward that is there and expected to spot it. So, right. So just something to kind of touch on is unfractionated heparin. People will have different degrees of experience with it. I found it quite scary for whatever reason when I was going into F1. The reason heparin infusions are very useful is because they're a continuous infusion which can be rapidly reversed. And a lot of patients on vascular wards will be on it because the indications for using a heparin infusion are kind of myriad, and I won't go into that now, but you will see patients who are on heparin infusions. For example, if they need to be bridged for warfarin preoperatively and postoperatively, patients are given heparin as a bolus if they've got acute limb ischemia. So you'll be seeing a lot of heparin around. And it's just good to kind of have a general idea of what the guidelines are around monitoring and who should be doing what. So before, you need to be doing a full kind of panel of blood. So a full blood count, U&Es, a coag screen, and LFTs. And if there's anything deranged, then speak with the hematologists. And, that's kind of you done. You're not expected to be acting on any obscure blood results in this context. So what we're monitoring in with a heparin infusion is the APTT ratio. So the target range is typically 2 to 3, but again, that can change. A lot of these things are subject to local guidelines, even though there is national guidance. So if in doubt, there will be a guideline for your trust on your trust intranet or EOLAS or whatever the trust uses. So just that there will be something to fall back on, which is easy to forget in the stress of the moment when someone says, start them on a heparin infusion. The APTT ratio needs to be checked 4 to 6 hours after starting the infusion and after any change in rate. Now, the nurses will be changing the rate, and sometimes they'll change the rate and then do the bloods, but you'll be expected to review the bloods. Now, that doesn't mean that you need to be doing an APTT ratio every 4 to 6 hours that someone is on a heparin infusion, because people can be on them for multiple days and you don't want to be stabbing them multiple times a day. So if the APTT ratio is in range, it should be checked at least once daily. And you should also be doing a full blood count once daily to look for heparin-induced thrombocytopenia. And, obviously, if you notice that their HB is dropping, then consider that they might be bleeding, do a clinical review, think about all of these things. And then after a heparin infusion, so you need to make sure that if someone has a target range for their anticoagulation, that they're within that range before you stop the infusion. Someone doesn't need to be on a heparin infusion for the entirety of their bridging. So if they can be switched to enoxaparin, then do that, because it's obviously slightly less invasive. But the salient points are: know what it is and why it's useful. Know that there will be guidelines on what you should be doing and what other people should be doing, and when you should be escalating things and who to talk to. And it's always better to ask, so don't be afraid to ask. Okay.
All right. Thanks, Anna. So moving on then. So if we take a case of a 50-year-old male who presents to A&E with abdominal pain, you take a brief history of his pain, quick Socrates. He tells you that it's all over his abdomen It started yesterday morning. He describes it as an ache, and he says that it radiates into the back. He vomited at lunchtime, and in terms of the timing of the pain, it went away for a couple of hours yesterday, but has been constant since this morning. And he describes the severity as a 5 out of 10. In terms of his past medical history, he's previously had investigations for possible COPD, and he's on Ramipril for hypertension, but it was last issued 2 years ago, and that may give you an indication that, you know, his blood pressure may or may not be well controlled. Then you go on to examine the patient, and in terms of
just struggling to get. There we go. Sorry.
That's right. So you do some quick observations. You find him to be using 3. Temperature of 37.1, blood pressure maintaining around 112/79. His heart rate is high. He's tachycardic with a heart rate of 103, and he is saturating 97% on room air, but a rest rate of 21. Generally, at the end of the bed, though, he's uncomfortable, and you can see that he's got a raised BMI, so he's overweight. His hands are warm and well perfused. His radial pulses bilaterally are palpable, but slightly thready. And like we established already, he's tachycardic. He's grossly euvolemic, though. His heart sounds are normal. His chest is clear. His abdomen at the moment is soft, but it is tender to palpate. And no pulsatile masses are felt on examination. So how worried are we, and what are our next steps? So we want to do some imaging, okay? And you may choose to do an abdominal ultrasound, but if you're in A&E and you've got the CT right around the corner, then you may wish to do a CT abdomen pelvis. And you can see, hopefully, you can at least spot that there's something quite abnormal on these CTs. So I don't know if someone wants to put something there. Maybe anyone's got any suggestions in the chat. If not, then that's fine. But yeah,
I'll just keep an eye.
okay.
No, nothing in the chat.
Nothing. All right. So other clues you might want to look for in your history. So if we go back to the imaging, actually, we might as well point out the obvious. So as you guys can see, especially in the CT, hope you might appreciate that, the aorta is absolutely massive. Okay. And you can see it's quite calcified there, but much larger than it ought to be. And I'm not sure what the bottom arrow is pointing towards.
So that's pointing towards blood in the retroperitoneum.
Okay, so we can see here, actually, it seems like it's coming from both sides. I'm not sure if that's just me, but it seems that there's a leak, definitely in the retroperitoneum, but also maybe on the right-hand side as well, a little bit. Anyways, so other clues that you might want to look for in your history. So there could be a recent PR bleed, and this could be indicative, of course, less common, but indicative of an aortoenteric fistula, which can take place. Has the patient already got known, AAA? If they do, or the way to find that out is either looking through the clinic letters, maybe if they're already known as a vascular patient, or previous CT or ultrasound abdomen reports. And of course, something really important to look out for is a personal history or a family history of connective tissue disorders. So that's things like Marfan's or Ehlers-Danlos syndrome, things like that, which we know, of course, are more common. AAAs are more common in such patients. So what keeps most patients with a leaking AAA alive? So we saw in the scan, this guy had a leaking AAA. Why do we think that most of these patients stay alive? So for those of you watching the recording, maybe pause it and have a little think. But for those on the live, The answer is because even though his the AAA is leaking, most of the AAAs that do occur, around 80%, exist in the retroperitoneum. Okay, so that means that any bleeding that does occur does not take place in the abdomen, and that means both that the bleeding is somewhat restricted because there's less space in the retroperitoneum, but also because the abdomen and the organs within it are not as affected. So this gives the patient time, increased time to survive before he's then operated on and a more definitive management is done. Now, what are you going to do? Straight away, you need to refer this patient to vascular surgery. And you may wish to transfer depending on where you are or the situation that the patient is in. So if there isn't a vascular team at your hospital, then you may wish to transfer the patient, or maybe a vascular surgeon and the associated team can make their way to where you are, if that's quicker for the patient. Of course, something really important is that you want to get instant IV access to large bore cannulas into this patient. This patient will be losing his circulatory volume, and so that needs to be topped up. If it's not, then he'll go into a state of hypovolemia, hypovolemic shock, and it could be fatal. Avoid hypertension. So if his blood pressure, so we noticed actually, although in his on his observations, the blood pressure appeared, usually you wouldn't bat an eyelid to that. It's a pretty normal blood pressure. But we know two things. Number one, this guy has a history of hypertension that's most likely not controlled at all because he's clearly not taking his blood pressure medication. And number two, based on the CT scans, he's bleeding. So although that appears normal, it's very far off his baseline, which is probably, I suspect, much higher than that. So it's always important to take things in the context of what is kind of the patient's baseline or normal for them. Thanks, Anna. So yeah, you want to make sure if there is any hypertension, you avoid that and treat that urgently, because that's going to be pushing more blood out of his circulatory system. Provide the patient, of course, with pain relief, and make sure to complete all the preoperative bloods. So clotting screen, make sure to take a group and save. I would do a cross match for this patient anyway because he's already bleeding, but all the bloods that you would need, user needs, etc., to look at the kidney function, so on and so forth. Fine. And then the actual procedure that takes place is a repair of the aortic aneurysm. Now, there's two main ways this can be done: either an endovascular approach or an open repair. And previously, the old data showed that there wasn't much difference, no significant difference between either approach. But more recent data shows that those that take the endovascular option have increase in their quality of life, their survival advantage, and generally reduce hospital costs and basically overall better outcomes for the patients. So typically, this tends to be the approach that is taken in most trusts because it's the one with better outcomes. Fine. So that's AAA. In terms of aortic dissection, now this can present quite similarly in patients. So where was I? So again, it's going to be sudden onset. Again, severe pain, but this pain reaches its maximum intensity within minutes, and often the patient will describe it as tearing. It often does radiate to the back or to the chest, but that kind of depends on where the dissection or the tear is. So anterior dissections will present typically with anterior chest pain. Posterior dissections typically with interscapular pain, so in between the shoulder blades. And the pain, of course, can migrate as the dissection extends. So the further the dissection goes, the further down the pain goes. Alternatively, the patient could present with syncope. and that's again due to them losing a significant volume of blood. Other signs depend on the direction of the dissection or the location of it. So you may get symptoms in line with Horner's syndrome. So that's if the dissection extends to the subclavian or the carotid arteries. And that, of course, if it does do that, then it will reduce the blood supply to the sympathetic nerves. And as such, you'll present with the symptoms of Horner's syndrome. So you can see that this patient has got ptosis, they have dry eye, and so on and so forth. You could get unilateral limb weakness, and again, that's going to be due to ischemia, again, depending on where the blood supply has been interrupted. So again, perhaps if it's, based on the Stanford classification, for example, if it's a type A or type B aortic dissection, then that will maybe give you a different presentation in terms of the limb weakness that you might suspect. And of course, you could get abdominal pain if the aortic dissection has gone all the way down to the abdominal aorta. Now, your management, again, this is not a diagnosis that you're going to be messing around with. This is very, very serious and can cause imminent death. So what you want to do is get the appropriate imaging, which is going to be a CT angiogram, and straight away refer the patient to vascular surgery, who would need to get the patient into theatre as quickly as possible. Fine. So that's those aside, AAAs and aortic dissections. On to some more hopefully useful tips, just generally for life as a surgical F1. So, of course, a big part of your job is going to be preparing your patients for surgery, and that means appropriate preoperative care. So, of course, things differ from trust to trust. The guidelines and whatnot. But generally speaking, there'll be rough rules to follow in terms of medications that need to be held prior to the commencement of the surgery. If a patient is normally on insulin, if they need to go on to variable rate infusion for whatever reason, but also advising the patient and thinking about when is an appropriate time for them to restart their regular medications. So medications that need to be stopped before elective surgery. So first comes first is anticoagulation and antiplatelet medication. So warfarin, for example, that's typically stopped 5 days before surgery. Of course, before the surgery, you're going to be taking a regular clotting screen and looking at the patient's INR. If the patient's INR is above 1.5, depending on the urgency of the surgery, then they may need vitamin K to be administered. Things like antiplatelet medications like clopidogrel and aspirin, typically you need to stop them 7 days in advance. Apixaban, again, there's no strict guidelines as such, and it varies from trust to trust. So the best thing is just to ask your registrar or your senior on the ward what is kind of the expected approach to take for apixaban or indeed any other form of DOACs. It's important that this is addressed and that this doesn't go missing, because ultimately this could lead to a delay in that patient's surgery if those medications aren't stopped. In terms of diabetes medication, so we've got a good table in the next slide that kind of highlights things. Again, this may vary from trust to trust, but generally speaking, there is different guidelines for different medications. So, for example, for your GLP-1 agonist, you've got no problems there. You can just continue taking them as normal, along with your gliptins, so your DPP-4 inhibitors, your pioglitazone, so on and so forth. But other medications such as metformin, which is, I guess, the most typical anti-diabetic medication, does have some changes that you need to be aware of, i.e. when to stop. So just I advise maybe take a screenshot of this table, but always refer to what your local trust says and what is normal for the department that you work in. Of course, as for variable rate insulin infusions, so remember that it is a possibility that both type 1 and type 2 diabetes patients could be eligible for an insulin infusion, depending on various different factors, including the regularity of their blood glucose, their HbA1c. So again, just check your trust guidelines, look for specific cutoffs and what is recommended in terms of fluid prescriptions, because there can be quite a bit of variation there. One really important point to remember, though, is that any long-acting insulin that the patient is on must be continued. So we we stop the short-acting ones, or there can be variable guidelines for that, but the long-acting insulin should always be continued. And the reason is, if there is no background insulin, what can happen is, as soon as the patient comes off the variable rate insulin infusion, then they can be at risk of developing DKA, and of course, that's the last thing you want as a post-operatively, when the patient's body has already been, undergone various insult and is at risk of various other complications. So that's if you're going to remember one point, that's the point that you want to remember. And finally, in terms of discharge documentation, just some practical tips here. Key information to include is obviously the surgery that they had, and whether or not it was elective or an emergency case. Of course, generally their post-operative state, what happened after their surgery. But of course, keep it concise. You want to make sure that, because often these operation notes are the first thing that doctors will read if the patient is readmitted for whatever reason, particularly within a few weeks or a couple months after their surgery. That'll be the first thing that they read. So keep it concise. Just only include the important information there. Any medication that was suspended, how long for, what the reason for stopping it was, if they're on warfarin or any other anticoagulation, when they need to restart that, or if they need to be followed up by, for example, if on warfarin at an anticoagulation clinic, to make sure that their INR is back to normal and in range for them. Any medications that were started and why, and again, what the follow-up plan is for that patient. And of course, remember, the discharge documentation is not just for other doctors to read, not just for the GP surgery, but also for the patient. So try and, where possible, avoid jargon, and also include appropriate safety netting for the patient. Of course, you're going to verbally pass it on to the patient, but you want to make that in writing as well. And I think we've come to the end. So we'll open the floor again for questions, and we'll keep an eye out on the chat. But by all means, you can submit them in the chat, and we could always answer them in the following sessions that we have lined up for you guys next week.
Regarding recording, someone's mentioned in the chat, the recording should be uploaded to YouTube. So yes, is the answer. And what I'm also going to do is put up the QR code for feedback, because that's really important for us, so that we know what worked, what didn't work, but also so that we can become better at teaching.
Okay. So I think in that case, we'll call it a day.
Yeah. All right. Thank you very much for everyone who joined, those watching the recording. Yeah, goodbye.
Lovely. Yeah, thank you very much, guys. Thanks.